So this course is going to be a very basic course. The aim of this course is going to, inspire people who have just not yet started on Toric to start doing it. It adds a tremendous value to our practice, to our patients as well. So this course is basically the aim of which is to help you to remove all the fears or remove all the intimidation which you would have to begin the Toric IOL practice, and we try to simplify as much as possible, help you to understand things. And we have got the best of the faculty here who are very experienced with the Toric intraocular lenses. So we'll be talking basically about the most basic steps, also about the image guided applications which we have. And then if you have any doubts, you can please write down. We'll try to sort them out at the end of the talks. So this is the order in which we'll be presenting our the presentations. So the first would obviously be, understanding the prevalence of existing astigmatism in our cataract age group patients, and how the SIA will be in our patients and how do we work it up. And to begin this session, I would like to invite Dr. Bharti, and she'll go to speak us on, to help us understand the prevalence of astigmatism and relevance of Toric intraocular lens practice in the current times. So may I request Dr. Bharti to come and start her presentation.
Good morning, everyone. I would like to thank Dr. Deepak for this opportunity and also the AOS Scientific Committee. First of all, we need to demystify and debunk the theory that we need high-end gadgets and equipments for the practice of toric IOL implantation in our cataract workflow. So let me begin my presentation. In my own personal journey, I had initially some overwhelming thoughts about the terms, the words which were used in the practice of toric IOL implantation, and I had my own kind of anxiety about using these toric IOLs in my cataract workflow. So, over a period of time, the confidence has built up. And as we see, the scale of the problem is almost 30% of the cataract patients who require surgery would require a toric IOL. This would mean every 2 to 3 patients out of 10 would require a toric IOL. This is justified by all the data and all the statistics which are obtained from all the journals. At least 30% of our workflow would require a toric IOL. Coming to the case, first case here, he is a 70-year-old man. He is scheduled for right eye cataract surgery. He has, against the rule, astigmatism. In this patient, we were able to do only 2 basic tests. Biometric values which were obtained are auto-K reading, which were repeatedly consistent, suggesting a cylinder of 0.75, axis of 106. We did not have optical biometry. We did an immersion scan. The immersion A scan also agreed, and the topography also agreed on the magnitude and the axis of the cylinder. So this is the patient who opted for a toric axis of IQ, and this is the final printout which the Alcon toric IOL calculator gave us. Patient required a T3 series of IOL, toric IOL at 10 degrees. So what I try to emphasize here is we didn't have optical biometry in this patient. We did not have any other ways of estimating the postercorneal astigmatism. 2 simple tests which conversed on the biometric values, we were able to get a emetropia target of 6/6 in this patient. Coming to the next patient. Here again, this is a 65-year-old lady. She has, against the rule, astigmatism of -1.5, axis at 87 degrees. And when we see, we obtained 4 important biometric measurements from auto-K reading, a topography scan, immersion scan, and also IOL Master 700. This patient had chosen an Indian Toric. They own these IOL manufacturers themselves have their own Toric formulas, and finally we could obtain a Toric lens which had to be implanted at steep axis of 174 degrees, and patient did well and obtained 6/6 vision. So, to conclude from these two case studies, we can now understand that against the rule astigmatism is the most commonest incidence, and also we did not have high-end equipments to do or incorporate toric IOL in our workflow. So coming to certain simple aspects of astigmatism or refreshing the astigmatism principles in our practice, we have regular astigmatism, which is the most common indication for using toric IOLs. Regular astigmatism can be with the rule or against the rule. In with the rule astigmatism, the steep axis is at 90 degrees. In against the rule astigmatism, the steep axis is at 180 degrees. Whenever we counsel patients for toric IOL implantation, there is a flexible plus or minus 30 degrees from the steep axis. As you can see, 60 to 120 degrees and 30 to 150 degrees. So plus or minus 30 degrees, we can still counsel the patient for a toric IOL implantation. So coming to the progression of astigmatism as we age, in infancy and childhood, it's usually with the rule or against the rule. In the middle age, it turns out to be with the rule astigmatism, and as we age beyond 50 years, generally it is against the rule astigmatism. Coming to the second important aspect of surgical induced astigmatism, astigmatism that is observed after routine phacosurgery, each surgeon has a surgical induced astigmatism. Over a period of a decade or so, it has been observed that it is based on the size of the incision, and generally when you are a temporal phacosurgeon using a 2.2 to 2.8 millimeter incision, you are inducing almost negligible astigmatism or around 0.1 diopter of astigmatism. So whenever the biometry online toric calculators use a assumed value of 0.1 diopter, it is because they have seen that these temporal phaco incisions are least astigmatic. So they are assuming that the astigmatism induced by these incisions is around 0.1 SIA. Of late, SIA has least importance in the workup. There are multiple websites and softwares available to calculate the surgical induced astigmatism. But what is important now is concept of the posterior corneal astigmatism. So here the total corneal astigmatism is the sum total of the anterior as well as the posterior corneal astigmatism. Sometimes the surgeons used to experience refractive surprises whenever they were not considering this posterior corneal astigmatism, and so they saw the role of the posterior cornea as a refracting surface. Anywhere around 0.3 diopters of against the rule astigmatism of a minus lens, meniscus lens, is assumed to be contributed by the posterior cornea. So as we can see here, when the biometric value of the K reading is obtained, when you see the K 1.09 plus 1.09 diopter at 171 degrees, but the total K is 1.45 diopters at 174 degrees. So 0.40 diopters would have been missed. This is contributed by the posterior corneal astigmatism. Devices which measure posterior corneal astigmatism are these, but it is not mandatory to have all these devices in your workflow. Workup of the patient includes a case selection, accurate biometry, and IL power calculation. Case selection includes ruling out pterygium, dry eye, and other aspects. Senile cataracts, usually more than one diopter, is the usual indication. In my practice, I would be low on my threshold for against the rule astigmatism. Usually 0.75 is the cutoff. With the rule astigmatism, 1.25 diopters or more. There are ever expanding list of indications, but most of the times for a beginner surgeon, stick to the conditions of simple cataract without any irregular corneal surface due to pterygium or any other ocular surface pathology like dry eye. Keratometry reading has to be taken multiple times so that we see that the multiple readings are concluding on the values. Coming to these formulas, these are excellent formulas, especially the Barrett-Toric calculator is an excellent formula. Suppose you would want to choose an Indian IOL, the Indian manufacturers themselves have their own online calculative devices through which they would be providing you the sheet for you implanting the IOL, including the access to be implanted. So we have Acreol and Biotech, I think. These are the companies where we do get IOLs from Indian companies. Let me rush through this video. So in a post-polar cataract, okay, yeah, finally. So a 4.5 millimeter excess is done here, and after the nucleus removal with the chip and flip technique, the cortex is removed. There is central plaque here. The manual marking of the axis is done in the slit lamp in this patient. The toric IOL, chosen IOL is implanted in the axis. So few years back, post-polar cataract was a relative contraindication for the implantation of the IOL, but of late, even in post-polar cataracts, we are able to implant toric IOLs. To conclude, for any beginner surgeon, we always have a mental block that machines are ahead of us, but it is the surgeon. We can work in conjunction with the machines, in tandem with the machines. We need not have high-end machines like topography, Shimfloop, Pentacam and all. It is good that we have because most of our panelists and here co-instructors do have, but for a beginner surgeon, a simple ultrasound biometry with multiple K readings which are consistent can also help in the beginning of the toric IOL implantation. With this, I would like to conclude. I now invite Dr. Deepak.
So I think the first take-home message from this presentation is that, as we know, when you begin our practice, we may not have the financial resources to have every gadget which is ideal to practice. But even if a simple auto K reading, you can start doing the toric lenses. The beauty of this thing is, the margin for error is quite significantly high. It is quite safe. You can always go ahead and start doing your toric lenses as and when your resources improve, you obviously can add all the gadgets. So first take home message is, even with your regular A scan with immersion biometry and good readings from your autokeratometer reading, you can start doing your toric lens implantation with excellent outcomes. So the next, once you decided that you're going to operate and put a toric lens, how do you measure or how do you mark? So this becomes the next more important thing. And as we all know, there are multiple techniques of marking on the cornea, including image guided devices. But I'm trying to be very simple and practical, which and every ophthalmologist who is doing cataract surgery can use these techniques. So, as we all know, the quality of the vision is extremely critical. That is the reason why we need to correct all these patients who have got astigmatism. As has been told, our threshold is, anything above zero point 0.5 against the rule astigmatism, we would always decide to go ahead with the toric lenses. Thankfully, in our country, we have an option of good intraocular lenses as well, which are much more economical and do a decent job. So, the cost of the lens itself should not deter you from venturing into toric lens practice. That should be the first take home message. And why do you have to be so conscious in getting your marking right? The relevance is, the error can happen at every stage. So when we measure, they can have an error, calculation error, marking can error, and even during IL alignment, final alignment, you can have an error. So it can happen at every step. These are the four stages at which error can happen. So to keep it very simple, I want to simplify as much as possible. We are to having two marks. One is the reference marking. That is, you want to have a 0, 180 degrees. That is a reference on which you are going to base your marking for the axis. The IOLs have a marking. IOLs usually have to be placed on the steeper axis. So to get everything right, you have to have a perfect reference marking, that is 0, 180 degrees. And most errors happen because of errors in this reference marking itself. So we need to ensure that to ask ourselves one question: are we marking 0, 180 degrees? Is it accurate or not enough? So one of the most common errors which can happen is head tilt when you're trying to mark at the patient's slit lamp or in the operation theater, freehand marking. The most common error which I feel is a little bit of head tilt which can be missed by a naked eye. And this is where we want to validate our reference marking using the gyroscope technology, and which is available in our smartphones. And thankfully we have got two excellent apps. Android, which I use, is iToric. Dr. Saurabh Patwardhan's here, he's here only. And people who are using iPhones, they can use Toricam, Dr. Barrett's app. And basically what these apps tell you is that, whether your horizontal reference marking is good enough or not. So because that is the most important source of error. And I'll just show you, like, what is the best way to do it, or how I am going to usually mark my cases. So let me begin by showing you how we do it in the slit lamp. And this is a video which so basically, you have to anesthetize the patient at the slit lamp using local drops, and having a drier cornea ensures that you have a slightly thinner spot. So I'm using a 30 gauge needle. I prefer to use a speculum, and asking the patient to look ahead straight in the light. The light is 10 at 0 and 80 degrees. What I'm doing is switching between two eyes, so that ensures that, head tilt is minimal. If it can cut across the Herbert reflex at both the times similarly, then we can know that, your head tilt is minimized. Once you have this horizontal marking, then you are going to confirm by using the app which I'm going to demonstrate. So ask the patient again. So what we're doing is, looking here, the patient's head is always stabilized by an assistant so that it doesn't move back. Most of these patients are old. They require some help to minimize this thing. And this is the slit lamp video, and this is an external photography. So I prefer to use a 30 gauge needle and just use a superficial stromal puncture, not just a marking. So usually what we do is we go ahead and puncture the stroma so that it stays in for long. The idea here is, the case may be sixth or seventh on a list, and by the time the turn comes, the ink mark can vanish off. But if you have a puncture there, the mark is always going to be there. This is other way of marking. It's the traditional way at the operation theater itself. Again, here I would like to ensure that, because some of these patients would be squeezing. Best would be always to use a speculum to do that, and use a bubble marker to mark this. Again, you are going to use this app to confirm your how it is, whether the horizontal reference marking is accurate or not. And always, my preference is always to do this app marking even at the slit lamp. So this is what I use. Again, the idea is, the patient is sitting at the slit lamp with a good illumination. The head is stable. You get excellent photographs by using this. And you've got those rings, and the rings have to be, the largest ring has to be aligned with the external limbus. And then you have got calipers, which you are going to align with the mark which you've done. So what basically the app is going to tell is how much off axis are you really with the general 0 to 180 degrees. That is what we want to find out here. So by using this gyroscope device which is built in, we come to know how much off the axis it is. So usually if you're very good at it, it's seldom more than 1 to 2 degrees. But definitely using this app along with your marking at the slit lamp, it gives you excellent accuracy which can be compared even with your uh, imaging devices. So it almost the thing would be is almost the difference would be very negligible. So we are using this device, and it has provided us excellent outcomes. And I don't find much difference by using a compared to using an imaging device which are quite expensive. Now moving on to the intraoperative alignment. Obviously, the most important aspect is once you're marked, the surgery is going to be extremely routine. You have to have the basic principles that you have to have a good rexus, very well centered rexus. That is the key which is going to hold the lens in position. Most of the lenses which you have in the market are hydrophobic, where they're going to stick onto the capsular bag pretty well. And maybe once you go in, you can always re-enhance the marking, and you can use the implantation of your choice. Here I'm using hydroimplantation. Even if you use viscoelastic, it is fine, no problem. Only ensure that once you're done it, you empty the bag totally of the visco and the posterior surface of the lens, because viscoelastic inside the bag or behind the posterior lens, that can cause the lens to move around a little bit. Just ensure that you don't have any viscoelastic at the back, and then you align the lens appropriately. The only, usually these lenses stick on very well. I haven't had much experience of rotation post-operatively, especially the hydrophobic lenses. Now, once you do it, it's important that you tap the lens posteriorly and ensure that the eye is a little bit soft, so that the apposition between the posterior capsule and the posterior surface of the lens is there, so that it sticks on quite well there. So I have not, in my experience, noted a significant rotation. I have been following them for quite some time. And even if it rotation happens, it usually happens in the first 10 days, maybe first day itself, the maximum rotation happens. So if you are having any abnormal refraction the first post-op day, always go ahead and try to dilate the pupil and see whether the lens is sitting in the intended axis or not. So this is what in a dilated examination, maybe after just this 1 week or so, you're just trying to dilate and see whether the axis it is holding on to the area where it is there or not. The most important aspect is, when in certain situations, like in patients who are having myopia, who have a large bag, those are the situations where I would use a CTR in the place. The idea of using a CTR in these eyes which have got large bags is to ensure, one thing is it stretches the bag, it brings the posterior capsule forward a little bit. The adherence between the posterior surface of the lens and the capsule is much more earlier and stronger, and that's the reason why the chances of lens rotation are slightly minimized. So watch out for the eyes which have got bigger white to white ratios, and then maybe in those situations you can use this. So I always prefer to use the slit lamp marking over the freehand marking, just to enhance the accuracy and reconfirm by using an app. So either you can use an iPhone app, Toricam, or what we use is the Android phone, and you can use a Patwardhan iToric app. And I have found that the acceptability or the post-op accuracy is significantly better than your freehand marking. And even taking this the photograph and using the app, I prefer to do it on the slit lamp where the illumination is very good. And the third tip would always to be having a superficial stromal puncture, because even the ink goes off, you have the puncture for you to know. So with that, I think I'll conclude my presentation. I'd request the next presenter, I think Dr. Anurag, to come and do his presentation. So please note down all your questions, the most basic ones as well, and we're going to have a discussion at the end of all the presentations. Thank you.
Thank you so much, Dr. Deepak, for including me in this wonderful IC. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. I'm here to speak to you on few practical tips and image guidance in particular, which is important in toric IOL practice. I'll come to the practical tips later. We have been hearing that the image guidance system is not necessary for a toric IOL practice, for a good toric IOL practice as well. And I partially agree with that. See, there is a good and bad system in everything. Every equipment has a flip side to it. Every instrument has a bright side to it. So let's talk about the good first, the good aspects of this particular image guided systems first. What is the good? The good is it has a very dynamic keratometry. As you move the joystick and as it comes to a focus, it already starts mapping the corneal meridians. And this is how it represents it. There is a digital Mendes ring all around the limbus, and it marks the steep and the flat meridians. Then it gives you a picture. It gives you a set of three pictures. You are to choose which is the best one, which is the clearest one, and then accept it. The next thing you do is you feed the axial length, lens thickness, and ACD into the machine, and then it gives you a printout. The printout that comes is down below in this green zone, in this green banner. As you can see, it gives you the expected refraction at the spectacle plane, the sphere, the cylinder at the spectacle plane. So you can adjust. How can you adjust? Let's see an example. This particular patient, okay, before we go to that, just before you start your surgery inside the OT, this is what comes up on the screen, the whole summary of the case. So you cannot miss out on which patient and which eye and which toric model have you chosen for that particular patient. The whole summary comes up before the machine goes ahead and registers the eye. And how it registers the eye is, it has clicked a picture preoperatively in the planning unit. It matches that with the eye picture that's coming from the microscope with another device that's sitting on the microscope, and then they cross match and they tell you that this is the eye that was to be operated by you on such and such time. This is where I say I partially agree. Now, you can say that I land bang on 180 degrees every time I incise, but when you switch on the image guidance, you can see that it off axis on almost by 20 degrees. With a 2.2 millimeter incision, it doesn't matter much, maybe. The 2.2 is the SIA, but if you're not incising along the steep axis or the axis where you've planned it and you're putting it elsewhere, then the resultant becomes 0.4, you're off axis by 0.4, and that is what makes you, that's what makes this significant. It has a very dynamic tracker, so all around the, some of the patients move their heads, move their eyes a lot, so it constantly keeps on tracking and keeps projecting the image back so that you know where to enter and which axis to incise if you are an on-axis surgeon. Let's talk about the clinical application. This is one patient who had come to me ready for the surgery. That the patient wanted surgery on that day. The machine told me that the patient needs a T3 with a residual astigmatism of 0.06 and a equivalence of 0.01. The inventory at the local distributor did not have a T3, but it had a T2 for that particular spherical power. I asked the machine, can I implant a T2? The machine said, yes, you can. You can go ahead with a T2. The spherical equivalence will still be 0.01, but what you have to change is, you have to change the section size from 2.2 to 2.8. So that's what the meaning of planning is. That's what planning is all about. This is another patient who wanted a trifocal, and we found out that the residual astigmatism was not acceptable. It was almost at 0.58 as is shown here. So the patient chose femto, so we planned an arcuate incision, paired arcuate incision along with it, running for 22 degrees axis at such and such locations at a depth of 85%. And once you do that, then the incision, the delta value comes out to 0, which was very, very acceptable, as you can see down below in this planning sheet. This is another patient's example who needed a T9, but still there was some residual. This patient also chose a femto platform, so we planned the arcuate incisions accordingly. The only thing that changes is the arc length from 22 degrees in the previous case go to 24. The depth is 85%, and the diameter is still 90%. This was another patient who had an expand series of 3 diopters. You know that in that power range, the toric IOLs do not come. So we had to take the machine, the help of the femto machine to produce a pair of arcuate incisions. This patient's second eye was operated by me. You can see the autoref screen, it shows 0. But the first eye was shown, the surgeon had done a wonderful job, but he had left a cylinder of -1.5. So let's go to the not so good aspects of this image guidance. The keratometry fallacies are there because it measures the keratometry on a single ring, not on 3 zones. The calibration has to be done almost every day in your office. It is not impossible for that machine to register a wrong eye. As we saw, the summary is projected. It's not impossible for the machine to register the wrong eye. It is not unlikely to fail to register the right eye too. Like for this, in this example, the eye is right, but the registration has failed. So you have to go back, just switch the machine, tap one button where the machine understands that you're trying to override the automated registration process and you're trying to manually do it, and then the machine registers the eye. And that you can do only when you have access to it. So let's come to the practical tips. This is one example where the tracy refraction shows a minus 3.3 cylinder. When you come to the delta from the cornea, it is only 0.12. This happens when there is a lens tilt or a subluxation which is subclinical. It is not evident to you clinically. So the eye trace shows you that the internal aberrations are way too enlarged, and the delta and the tracy refraction are different from one another, because eye trace calculates the tracy refraction on the anterior lens capsule. So it takes into account the corneal cylinder and the lenticular cylinder combined. So something you always should be watching out for. The surgical tips, I would always prefer to put the IOL under the cover of BSS, not use viscoelastics for it. CCC overlap should be there, geometrically good and watertight incisions. However, you should not make them too watertight at the end of the surgery while you're trying to irrigate from the side port. Look at what happens in this case. For example, I have aligned it properly. The IOL is perfectly set, and this is a premium toric. This is not just any toric, the premium toric, and all my the toric lenses that I put are premium. Then I'm trying to irrigate it. Look at the IOL's behavior. It rotates. So you should not, this was a very frank rotation, so you could catch it on the table. It might rotate subtly and you might not be able to catch it on the table. So it is not a good idea to make very watertight incisions. When you're trying to align the IOLs, these are the points that you must look at with the image guidance. There is a hyperbola out here. There is a ball that traverses through the hyperbola, so it should be there in that range, in that hyperbola range, and the message that should come down below is tracking okay. If the message is center the eye, you should go back and center the eye, but that's when the image guidance, the axis of alignment is at its proper location. If you do not see this message tracking okay, then you should center the eye and adjust it a bit so that the message changes to tracking okay. This is another example wherein, I mean, with practice, of course, you learn it. This is the toric IOL that comes in. You leave it there. You have asked which is the axis of placement, and once you switch on the variant axis, it is bang on. So I always ask on which axis I should align the IOL. If the assistant comes with a response that it is 170 degrees, I know roughly where 170 degrees is. So I take the IOL there, the dots there, so that I don't have to rotate the IOL too much once it's inside the bag. Where it actually helps me is small pupil toric alignment. If you've left the IOL very close to the desired axis of placement, in a small pupil where you actually cannot see the IOL dots, the Y hook goes, spreads the pupillary margin, and lets you know that you have to rotate it maybe marginally to come to the axis. But if it's wayward, if it's maybe 90 degrees away from where you should leave it, then a lot of rotation has to be done. And it's a difficult task in a small pupil because you still don't know where the IOL marks are. So this is another practical tip. This is one of the fallacies of the image-guided system. Look at what happens here. I'm trying to align this IOL along the desired axis, which is 173 in this particular case. And I align it to 173. Look at the message that comes down below. It still says tracking okay. Now it says center the eye and the axis shifts. So this is what I meant. So if the message is not tracking okay, you're not on the proper axis. So I move it back to where the renewed axis is. Once I do that, the axis shifts again. So it kind of plays a little trick with you there. See, it changes again. So it kind of plays tricks with you there. So you have to be careful and look at these messages and these parameters before you align it properly to the desired axis. Parallax is a phenomenon that always happens with toric placement. So what I go ahead and do is, if however I try, how much ever I try, I cannot align it to the desired axis, what I do is keep both the IOL marks on both the sides along the same, the orientation should be on the same side of the desired axis and equidistant from it. What normally people tend to do is they align along one meridian, which is distal to the to the incision axis and leave the proximal one unaligned. So that's not a good idea. This works very well. If you cannot align them, then keep them on the same side and equidistant from the axis of alignment. That's how it works the best in my hands. In the end, just before concluding, it also gives you the opportunity of analyzing your own surgeries before the patient's home page is exited from, data entry is done. Finally, what did you decide to put in, what spherical, what cylindrical power, and the SIA calculation, IOL power customization, if you need to do them. Of course, with the modern day IOLs coming in from good brands, it does not need the IOL power or the A constant customization to be done at all. But still, if you want to do it, then you can take 50 cases, compile them on this particular platform, and then come out with the outcome that you desire. Thank you so much, Dr. Deepak, for making me a part of it. Thank you so much, ladies and gentlemen.
Thank you, Anurag, for the wonderful presentation. I think we're going to have a lot of discussion on your topics. I request you to be back here and we'll have discussions. So now I request Dr. Saurabh Patwardhan to start his presentation.
Thank you, Dr. Deepak, for including me in this wonderful IC. And I'll be speaking about how to some situations we commonly come across while dealing with the Toric IOLs, and I will also add some innovative things which I have done in few cases. So first thing I want to, as Dr. Anurag rightly pointed out, I think small pupil and Toric IOL is always a trouble, because at the beginning, I think the pupil is quite dilated. By the end of the surgery, pupil becomes smaller, and in those cases, we have to improve the accuracy. So the first method to check where the toric marks are is to use the LIDRS in certain way. That means when you hydrate, in some eyes, the pupil dilates, and then you can check the marks and you can align it very well. So if those patients are there, you can use this trick. Other trick to use is to roll the eye right and left to see the marks if the pupil has become little bit of mid dilated. Here you have to take the help of the parallax, basically, because iris, the IOL plane is deeper. So if you move the eye right and left, you can see those marks at the end, and you can align them according to the marks that you have done. Here most of the cases I am using markerless system, but it's same when you are marked. Now this was an old case where the pupil became too small at the end after putting the IOL, and despite the adrenaline, it's not dilating. So in such case, it becomes really difficult. And so I tried all the tricks, but finally I was still not sure. So in such situations, what I do nowadays is that when I am expecting that pupil is going to go down, I make these additional marks. I help the manufacturer that I am going to add two marks on either side. These are around 3.5 to 4 millimeters apart. So even if you have very small pupil at the end of the surgery, you can see those marks. And these are just, you just have to touch that needle. You don't have to, bury it. So these are like little scratch marks, don't cause any visual disturbances. And you can see here, this was a very small pupil. I removed the B hex ring, and now I am going to nudge that IOL in the axis. And you have to really look carefully. These marks are very tiny if you have made it correctly. And I will just pause here and show you how the mark. So one side the manufacturer mark is seen, but if you see, there are two tiny marks. I will just pause somewhere here, and you will see that those tiny marks, you can see, those are, so even if pupil has become smaller, we can still align it perfectly on the axis, because otherwise it is in your mind whether I have aligned the IOL perfectly or not. So this is a nice trick to have in cases where you may expect that pupil is going to be even smaller and smaller when as you go. Now regarding, sometimes we have intraoperative meiosis, and then in such cases I would advise you to use a pupil expander or iris hooks, because it becomes really difficult to align the IOLs afterwards. So if you have a very small pupil to begin with, it's best that you expand the pupil, see exactly how you are placing the IOL, and I will show how to remove these expanders. So some of my colleagues told that we can remove the expanders under the hydro. It can be done, but I feel that in some cases where the pupil is really small, I will just show you in this particular case. So I have used B hex ring, I have aligned the IOL perfectly. Now under the irrigation itself, I want to remove this B hex, but I have seen that in such cases we may have some iris damage as because of the irrigation coming out from the, so it maybe you can use a small side port incision or do it. But now I have changed my technique. What I do is that I use the pupil expanders, I remove everything, entire OVD, I make sure that the alignment of the IOL is perfect. So right now BHEX is there is OVD. I am going to first remove the OVD completely, align the IOL to the perfect axis. So now I am going to remove entire OVD, keeping the B hex at its place itself. Just as previous speaker showed, the most important part if you want to improve accuracy is remove that viscoelastic from the posterior surface of the IOL, that makes it more sticky and stick to the posterior capsule much easily. So now it's the IOL is well aligned. Now what I do, I use hyaluronate, which is a cohesive viscoelastic in front of the IOL only, and then I remove the B hex very easily, because now AC is not going to collapse, the iris is not going to come out of the incision. And when we use hyaluronate, you just need a couple of seconds to remove that hyaluronate, and it doesn't really cause any rotation of the IOL. So this is the the way I am doing it right now, and quite satisfied with the result. So whenever you have these small people, these are few tricks you can use, and this is a very common situation we have with toric IOLs. Okay, next I am going to speak about the iToric app, which has already been shown by Deepak. So I will just move on how to use it. He has shown. I don't use bubble marker. I just use freehand marker. I will just show you how I mark here. Okay, so I have just done a freehand marking. No device is used. Just freehand marking, and the iToric app will give you the final result. This is how it looks. I think Deepak has elaborated it quite well, so I don't have to go into details. So before I had Callisto, I just had these two devices, an Android phone and a marking pen. That's it. Gave me excellent results, and still gives me excellent result when Callisto is not able to register the patient. Another use of this iToric app, even if you are using a slit lamp for doing the 0180 marking, make sure that your slit lamp is calibrated, because if you have say few degrees of error in the slit lamp itself for 0180, you may have consistently same errors in when you are marking. So you can calibrate the slit lamp also using this app. Just put it on the slit lamp's eyepiece and take the horizontal line, check whether it is exactly 0180. This is another innovation you can use in certain cases. I will show you in one case. It was really helpful. You can take a retro illumination photograph of the patient's eye. It can be done on slit lamp, or it can be used in these UVITS autoref. They have an infrared image. So you can take those photographs. They can be used for post-operative checking of the axis. It is very accurate with iToric app. If you have a retro illumination photos like this, you can exactly point out exact. This is very useful if you want to rotate the IL later. So you can feed that data and you get the exact. So this was an interesting case. A young boy, I think 5-6 years old, and very high astigmatism, almost I think 4 to 5 diopter astigmatism. So I wanted to correct that, but how to mark these young boys? This at that time I didn't have a markerless system. So this was the autoref image, retro illumination image, and you can see this zonular kind of cataract. I could mark those opacities, and then I could say that these opacities are marked. I have to place the IL at 25 degrees from that axis. So this is an innovative use of iToric cap. So this is an intraoperative image. So patient is under general anesthesia. So I marked according to those opacities, which are now even seen on table in the retro illumination, and I could get a perfect alignment in this particular case. So once you have some tools in hand, of course you can utilize them in certain cases, not in all cases, but they are quite useful. Okay, you can think out of the box and then align. So you can see I have marked it on table. This is how the IL is placed. I have done the posterior capsulotomy also, and patient did really well. I may have a post-op photograph also of this patient, where you can see that that's the post-op on the again autorefractometer retro illumination image. Axis is bang on, it's on the same axis where I had placed. Okay, just to finish, an interesting case we may come across when you are doing toric IOLs, when you get a ruptured anterior capsule. So this was an iris coloboma case, and I realized that towards the coloboma, the anterior the key CCC was actually ruptured. So there was a radial tear going towards the periphery. Now how to go about this? If you see my markerless system, I have to place the IL exactly at the same axis where there is a radial tear. So here you have to start thinking, a little laterally. So So what to do next? Okay, in this case, you have to have the thought process. So the plan was, when I realized this particular IOL, see the toric marks are at the site where the haptic start. So still I have got enough equator of the lens to place the IOL. So I went ahead with this IOL itself, same plan. Patient had around 4 diopters of pre-operative astigmatism, but the way to do it is very important. So you should not allow the the anterior chamber to collapse much. That colobomatous area is already shielded by hylucoat, which is a dispersive agent, so there should not be vitreous or fluid loss there. I am going to place the IOL exactly on the same axis, so I am not going to rotate it inside the bag. I am just going to place it exactly on the same axis. And even before I remove the OVD, what I am going to do is I am going to hydrate all the incisions. I am going to use very low IOP so that there is no sudden collapse of the anterior chamber. So there should not be shift or sudden tear or posterior extension of this radial tear. That is how I am going to end this case. So of course, somebody will say this okay on table. What will happen? Post operatively. Of course, you have to be watchful. What is going to happen? But I will just show you 1 month post op of this patient. And these some IOLs are really good, and they stick to the bag very well. So this is 1 month post operative after the surgery. The IOL is well placed inside the bag. You can see the haptic is there. There is already fibrosis. It's not going to move. Now I have almost 2 years of follow up of this. She is a one-eyed patient because other eye had a microphthalmos and this had a iris coloboma. You can see on iToric app also it is bang on in the same axis, and I could get away with a. Of course, we cannot use it in each and every case, but case to case wise, you can take decisions. Thank you so much. So these were a few situations.
Thank you, Saurabh. Thank you for the excellent presentation. Dr. Rishi is going to speak on some of the more complex situations wherein we are going to use. As he's going to set it up, I think one tip what I would like to suggest always, I repeated just to repeat, when you're using any of these apps, either the iPhone app or the iToric app on Android, try to get the photograph with the patient on the slit lamp itself with a good illumination. It makes job much more easier. The photographs also come very nice, and you can align the circles quite very easily compared to taking it on a in the operation theater itself. That also works well, but this is much more a better way of doing it.
So
That's
what I do, of course, our phones have those torches, but we can use an external torch
Yeah.
instead of phone's torch, because many times patients are even comfortable without phone's torch because it's not coming right
Right
from
in
the
front of
center.
the eye.
You can use the torch from side, so it will give a good illumination and good photograph. You can see even the conjunctival vessels.
And second thing is, I prefer to use speculum always, so that you get a better wider exposure. You that helps in getting the perfect view of
But
everything.
I think that is for the marking you use.
Even when you're taking photograph,
Okay, that's
it is
not,
done immediately after that.
that's really not needed. You can
Sometimes
do
the lead will cover the
yeah, if
superior
they have
limbus,
very
inferior
small
limbus.
concentrations.
Yes, that's the thing. That's one thing. One small tip. And let me ask by asking the panel now, what percentage of your regular surgeries do you have toric practice for the last maybe 2 years? If Bharati, you can start with this. Are you ready?
Yes.
You can just answer quickly. And then.
Around 20 to 25% of my workflow would be toric IOLs.
Yeah, I think 30 to 35%.
Anurag.
I don't know whether I can put that to a percentage, but I think we did around 950 torics last year.
It must be one of the highest. And well, in percentage, maybe 35% would be okay. 35 to 40%.
Could be.
So your limit is 0.5 or above?
My level is, see, that's also interesting. I don't have a threshold for a toric selection. I put all the data that I retrieve from a patient into the toric calculator. So whenever Varian tells me that the patient is suitable for a toric, or the Barrett suite tells me that the patient is suitable for toric, and I go ahead. So out of these 950, I think we did around 130 or 140 T2s.
Okay.
So our threshold for that is very low.
Okay. So, Rishi, are you ready? Okay. Okay, fine.
So the Barrett calculator and I think the toric planning devices, and those who have got IL master, what I would advise is that make the toric IOL calculation before you counsel any patient. In fact, before you see the patient, so that you exactly know whether toric IOL is needed for that patient or not.
Absolutely. I think, the counseling should start only after all your examination is done. The surgeon is going to decide whether this patient is going to have toric or not. So when you start talking, I think your counselor start talking, then you should say for your eye, this would be the best possible package or lens or whatever it is. Then you can give options, multiple options later on. So, okay, I think Dr. Rishi is ready with his presentation. Please go ahead, sir.
Thank you, Dr. Deepak, at the outset for involving me in this course. It's really a very comprehensive overview of all things toric IOLs. So, mandate given to me is to talk about some case scenarios related to toric IOLs. Since I am a corneal surgeon, many of these are related to irregular corneas, which may be scars or ectasias or post-keratoplasty. So we'll cover some of these scenarios, and we'll have an interactive session in which the panelists and the audience are welcome to give in their inputs. So I'll just go with some cases, and at the end of each case, we'll have a little bit of discussion. So this was the first case. It's a simple case. 16-year-old female patient was a chronic patient of allergic conjunctivitis along with ectasia, which we know is a known association. And because she needed steroids for the allergic conjunctivitis, she also went on to develop a posterior subcapsular cataract. Underwent collagen cross-linking. Once the allergy was under control, she underwent collagen cross-linking in both eyes within an interval of 1 week between the two eyes. And 6 months after the cross-linking, we planned for a phacoemulsification with a toric IOL for visual improvement. Okay, so all this has been covered. So surgery is nothing special. You go ahead and implant it like in your regular way. And since this patient didn't have much of irregular astigmatism, it was a well-centered ectasia. So we could go ahead and put a toric lens, and this patient got a good outcome. She got a 6x6 vision and was extremely satisfied with the result, and so were we. Now, there's no rocket science in this. It was a straightforward case, but there are some issues here, and it'll be good to get everyone's inputs. In a patient with a pediatric keratoconus, where we know there is the effect of cross-linking is not permanent, as the collagen turns over, we know that sometimes these patients can progress. Is it justified to go with a toric lens, number one? And what is the ideal wait time between a cross-linking and an intraocular lens? Not just in this case, in any case of an ectasia. So I request the panelists to just give their inputs.
Yeah, I think the general rule for waiting time, this applies for all corneal procedure, like even pterygium, because rather than C3R, is to have serially two topographies which are stable. If there is any change, then wait more. I think you are a cornea surgeon.
Yeah. For my pterygium cases, I think 3 months minimum you must wait. I've seen that till 3 months the topography tends to change. And after that, it's a good idea to repeat two topographies and see if there's stability and go ahead. So I think that's good enough. But I think in ectasia, post-cross-linking, we know that flattening can go on for a pretty long time. So I would say minimum 6 months, ideally a year. I think Dr. Vinod Arora wants to add something. 12 months is what you're doing.
But generally, like waiting for 12 months, should we consider like under-correcting or doing something else?
So yes, all those thoughts are there, and there's no perfect answer. I think I was looking more at making the patient emmetropic, and we can always treat
if you raise the repeatability of the biometry by 1, and instead of 2, if you take the benchmark to be 3, then perhaps, and all the 3 biometries have stayed stable, is what you see, then perhaps there's no reason to why we should tweak the correction. It can be an optimal correction as well.
Yeah. This is the other case. So this patient presented in November 2011 with me, 65-year-old female, known case of rheumatoid arthritis on systemic immunosuppressive with history of recurrent episodes of corneal melts, Sjogren's syndrome, history of episodes of viral keratitis also she had in the past. Now this patient came with long-standing burning and blurring of vision in both eyes. She was a classic case with these kind of joints, dry mouth, etc. She was in treatment with the rheumatologist. So her vision in the right eye was 618, left eye 69, a lot of SPKs, Schirmer's was low. And then we treated her. preservative-free lubricants, topical cyclosporin, referred her to rheumatologist. She improved slowly over time. And then she came again with in December 2011 with redness and vision drop in both eyes since 2 days. She had some atypical lesion with focal infiltration and edema in the left eye, and rest was as before. And we were thinking that she had a recurrent viral keratitis, differential diagnosis being a rheumatoid melt. We started her on topical antivirals, steroids, and lubricants. She resolved within a week, so it was probably a viral episode. After that, she'd been stable for a while, and this was her vision. Was going on with lubricants and cyclosporin. Again, had a recurrent dendritic keratitis. Again, with antivirals, lubricants, she settled down. Then we started on prophylactic oral acyclovir, resolved soon, and then was stable. But then after that, slowly, her vision in the left eye started deteriorating. And once she presented with an acute melt, again, we thought it was a rheumatoid melt. Tissue adhesive bandage contact lens was done. After that, she remained stable for a year, maintaining a vision of 6.9 in the left eye and 6.24 in the left eye. In Jan 2015, she deteriorated in her left eye vision to 6.36, and at this time she had a significant cataract. Ocular surface had been stable for a while, and she had a scarred, thin, vascularized cornea. The topography showed fairly regular astigmatism, so we decided to go ahead and plan a phaco with IOL. Now, at this point, one could argue that this is a cornea that has gone and had many episodes. It could again have another episode, and the corneal shape might change. So, whether to put a toric IOL or not is somewhat controversial. But in her case, she wanted a more of a refractive correction as much as we could give her. So this is what the cornea looked like. You can see there's a focal thinning inferonasally. There's quite a bit of scarring. Luckily, the visual axis per se was not so bad. And that's what the topography looks like. So you can see that you have a bow tie which is largely symmetric, even though it may be larger on one side. So we went ahead and did a toric IOL. This was a Technis toric, in fact, and under a cyclovir cover. That's what she looked like post-operatively. You can see that she got a very good outcome, unaided 6/9. Till now, she's maintaining that vision, and unfortunately, she's not had any more corneal episodes after that. So she's doing well, and that's what she looks like. And I will, even several months and years later, maintained its position. Subsequently, right eye phaco IOL was also done, and she's maintaining good vision in both her eyes. So discussion points here are, first of all, whether it was a rheumatoid or viral keratitis. Sometimes it's difficult to differentiate the two. I think that's outside the purview of this course, so we'll skip that. The important point is, should we have done toric IOLs at all in this case, or should I have gone ahead and put a monofocal lens and let the toricity be handled by a contact lens or whatever?
I think you did a good job there. I think counseling to the patient is extremely important. Their expectations, so they can't expect something how a regular eye would behave. So basically, our goal is to debulk the amount of astigmatism. You may not hit a bang-on reduction every astigmatism. Even if you can say, suppose the patient has 5 astigmatism, if you're reducing by 3, even 3, still the patient would be happy.
So that is
but
exactly.
Only thing, patient should not expect a 6/6 as unaided, something like that. That should be, you should be able to take the confidence in the patient.
I think that is the key thing in all premium lenses: expectation management.
Yeah, that is true. More so in these patients where it is debatable.
So I'll move on to the next case. If I'm overshooting, please let me know. I have lots of cases. I can stop anytime. So this was a 45-year-old male, advanced ectasia with cataract in the right eye. This is what the cornea looked like on OCT. We planned this patient for a manual DALC, and this patient was, had a history of an old hydrops, I think, and during peeling, there was a small perforation. Yes, but we managed to still go ahead and complete it as a deep lamellar keratoplasty. And this cornea actually did quite well. You can see that there's a little triangular perforation there, but eventually that didn't really matter much, and the patient got a very nice clear cornea, as you can see. And topography guided suture removal was done serially to try and minimize the astigmatism, but in spite of everything, the patient ended up with a lot of a significant amount of astigmatism, about 4.5, and this is how the eye looked post DALC. Now this patient also had a cataract, so after 1 year of all sutures being out, we did a toric IOL implantation, and This patient really did well. 20/20 part unaided vision. He still maintains very good vision and extremely happy with the outcome. So the point is that, okay, I'll just show you a few more ectasias with cataract. So this was another patient, 60-year-old lady with pellucid. You can see the periphery of the cornea is quite thinned out and elevated. That's what the cornea looked like in profile, and after the deep lamellar keratoplasty, she looked quite good. You can see that after some years, she went on to develop some interface haze and vascularization, but the visual axis was still quite clear. And slowly she was developing a cataract. So we went ahead and did a cataract surgery for her, and she basically got a good outcome. That's what she looked like afterwards. Best corrected vision was 20/30 with a toric lens, of course. So again, I'm sorry I don't have the topographies here, but if the topography is largely regular, you can go ahead and put toric lenses in ectasias. This was another patient of pellucid. One eye presented with hydrops, which we treated with gas. Other eye had significant pellucid, talc done, sutures out. After all sutures out, 8 diopter cylinder left. This patient actually didn't have a cataract, but because the patient was not happy to wear contact lenses, he was a driver, he desired spectacle or unaided better vision. So we went ahead and put a toric lens in a clear lens actually, and he actually did very well. We used, in this particular case, the smart toric lens from Care Group, which is basically a customized toric lens. And the beauty of this lens is you don't have to use your brain. You just have to insert it 0, 180. So the marks are already there. I've just put the lens along that axis, and you don't really need to do any other marking. It's all built into the lens. And you can treat very high cylinders with this. Only thing you have to be careful is if the cylinder is very high, the lens edge tends to become very thick. So sometimes you may have to make the wound a little larger and be careful while putting it through the bag. So this patient got a very good vision, as you can see. Do I have time?
No, I think
yes.
we'll just discuss something.
Thank you.
I think what you showed was the contraindications for toric IOLs are almost now none.
Yes.
It's coming from a corneal surgeon's perspective. He showed in ectasias, post KPs, and other things. Now let me switch the table and say, from a cataract surgeon or a comprehensive ophthalmology patient, from a doctor, you have any contraindications for toric lenses, like say pseudoexfoliation, loose zonules?
I think I will not say contraindication, but relative contraindication is keratoconus, where patient is still going to use scleral contact lenses afterwards. So there it's not required, because if you use toric IOL and then patient has to use a cylindrical.
Yeah, I think you absolutely nailed it. If it's a patient who's a happy contact lens user, just put a monofocal lens, because IOL induced cylinder cannot be corrected by any contact lens.
It's much more complex to handle that.
Yes.
So keratoconus is one thing where you would be better off doing this thing. Yes. Common situations like, you have a non-dilating pupil, pseudoexfoliation. In those situations, Anurag, would you go ahead and do? It's a wobbly bag.
Absolutely, yes. I'll have to rule out the lenticular cylinder part. That's the reason why I
That's
showed
okay, yeah. That you're done. You're taken care of.
So if that is not there and the corneal cylinder needs to be corrected, then obviously, yes, I would. Having said that, this only concern that there is you have to choose the IOL well, which has an excellent rotational stability track record. Why I'm saying this is because once you put in a CTR, you're essentially expanding the equator. So when the equator is expanded, the ring of Sommering formation is not that great over the IOL. So the bag is not going to be of assistance to hold the IOL properly. So the lens itself should have a proper loop memory, and the IOL we are putting in should have a good track record of rotation stability. But otherwise, these are not contraindications at all, per se.
Okay, next quickly. Rexis has gone radial. You planned a toric lens. Rexis has gone radial. Now, what would be the option?
I showed one in my case. So you have to, imagine how the IOL is going to land up inside the bag, and if there is enough equatorial space of the bag which is available for the haptic to be supported, you can put it. But as I showed in the video also, it's very important how you remove the OVD and keep the IOL stable without much fluctuation, because otherwise the radial tear may can also extend. So that is one.
And you showed one video of Bharti, you showed one video of postpolar cataract. In that case, you're lucky that the PC tear was very central and small. In bigger tear, I think would it be difficult?
Yeah, it would be definitely difficult if there is a radial extension of the tear. But if at all the tear does not coincide with the haptic marking, then you can always get away with putting inside the bag IOL implantation of a toric IOL. The haptic orientation should not coincide with the tear. So that is the thing. If it
No,
is
even if that happens, even if you have, that's just another option which we can consider. If the axis of placement and the radial tear have happened along the same lines, then what we can do is we can ensure that the aisle has unfolded in the bag where there's maximal support, rotate it to the site of proposed alignment, and then can do a reverse optic capture. That is one thing that actually keeps the aisle very stable. However, it is likely to actually take the residual refraction little towards the myopic side by a 0.25 or a zero 0.3, but that hardly matters in the long run.
If we have got many lenses with us at the stock, can you flip the axis and change the axis and put along the axis that? If you have got lenses in stock, that is another option.
You cannot flip the axis.
In the sense, there's a large difference, you can't do it. No? If the axis is too off, you can't do it.
That's a good option, sir. If you have a good inventory, then you can
Yeah,
flip the
you can do
axis
that.
and go on to the next. But the only thing is, we would perhaps not want the residual astigmatism if results from there on the against the rule side, because we know that there's an age-related drift that happens on the ATR side. So that is something that has to be kept in mind. But otherwise, the other thing is, for a particular spherical diopter, you might not have so many cylindrical in the inventory readily available to you.
I
The
think just would
other
like the flipping of axis is in the refraction, not of the axis where you place the IOL.
No. He's asking about the when you
radial
have the charge
extension.
coming in.
No, I think he's asking about the radial extension where you don't want to put the haptic in one way. You put it 90 degrees across if you have an inventory. I think a simpler thing to do would be just if the cylinder is not very high, put a 3-piece lens and try to do something for the astigmatism, maybe an opposite clear corneal incision or something.
Of course,
Yeah,
of course.
Dr. Birajda sir, I just want to, because there is a confusion. See, flipping of the axis is in the refraction. Unless you have a IOL which has, marks which are perpendicular to the haptics, that is not available. So, if the tear,
For example, if patient requires a T2 lens or T3 lens,
Yes,
the axis changes, which we take either T2
Yes.
or T3 in that way I'm telling. He
why
understands.
should the axis change?
See,
The axis will not change.
Axis will not change.
The axis will not change. The resultant
Placement
vector
of axis.
astigmatism on the output.
Axis will not change.
No. It
He's
comes out
actually
as
right. The axis is always along the haptic optic junction, whatever it is.
change the series.
the refraction.
I hope it's clear.
Yes.
No, we are ending up confusing more. So I don't think we can change the axis. The flipping is for refraction.
Yeah, but that's a good idea. You can give it to the manufacturer that you have, IOLs which are perpendicular. Like they should not be along the haptic, but so two set of IOLs. That
No, I think apart from that, we also needed desperately a multi-piece hydrophobic toric lenses.
Yes, very much.
That is
Sir.
the need of the hour. That is the need of the hour. Because you get excellent centration when you lock or go an IOL optic capture, and it'll be there for life. But we don't have a multi-piece
Maybe we can
toric
request
lens.
Aurolab to do it because they have a preloaded multi-piece
Yeah,
lens
that's the
anyway.
thing.
And they have the
So I
Toric
had
platform.
one patient. I think sir is getting ready, sir. Satyamurthy sir.
Ready?
Yes.
One
So I
more
had
question
one
to Dr.
young
Deep.
young patient, bilateral frank posterior polar cataract, and she wanted only, and she had cylinder also. She wanted toric trifocals only. So she was referred by another ophthalmologist to me. So what I had, just at that time I had to think about all the possibilities, what can go wrong. She was a young patient. So what I did, I kept the 3-piece multifocal ready for her. I told her, and I told her that post-operatively the cylinder I will take, correct it with surface ablation. So, that option you can also have in mind. So patient knows that if something goes wrong, this is the plan I am going to follow. So that.
So before sir gets ready, I think I want to ask Dr. Deepak, what kind of pterygiums you would want to operate before taking up the patient for toric IOLs?
Ideally, I think the best case scenario, every cataract patient who has a pterygium, we want to operate before, because we want to regularize the cornea, wait for it to heal, and then typically maybe 3 months. But this scenario does not exist because many other times patient may be having intermittent cataract, mature cataract. In those situations where we would have to venture out and remove the cataract. But the ideal situation, most whenever we do a keratometry and have some amount of astigmatism, those are situations where I would advise a pterygium, dealing with the pterygium first, wait, and then go ahead and do a cataract surgery.
I had a very interesting case which was posted for a multifocal toric lens by my counselor slash optometrist. After we have seen an advised cataract, the patient went and chose multifocal, and because the biometry was showing high cylinder, she chose multifocal toric,
Toric.
counseled the patient. Then I said, why is the cylinder so high? 5 diopter cylinder. Something is wrong. Pterygium was there, very, very small pterygium, which even I didn't pay attention to. A small peripheral pterygium was causing so much effect on the central cornea, on the topography, because we do a optical biometry which has a topographer on it. And I realized that this patient cannot have a multifocal.
It has to be
Yeah.
very deep and very fibrotic.
So
It
it
always
was
flattens
a very peripheral pterygium, atrophic type, which you normally would not think would cause, but sometimes even small pterygia can have a lot of effect. So it's a good idea to just take them out and then do it as a second stage. Otherwise, do it as a monofocal lens. That patient afterwards had 0 cylinder.
Yeah,
I took out the
because pterygium is probably the most common reason for having cylinder in our patients.
Exactly.
You always keep a close watch whenever you have cylinder. Always
and
look
don't
for
go by the appearance. You have to
the-
look at the
yeah,
topography.
topography. I think now we'll go to Dr. KB's. 10 minutes. So, what do we do when we have post-operative residual astigmatism? I think Dr. KV Satyamurthy sir is going to talk to us about that. Sir, over to you.
Yeah, good afternoon. At the outset, I would like to thank Dr. Deepak MEGUR for giving me this opportunity to be a part of this program. I think most of the difficulties have been discussed already. I don't know if I was not here. Anyway, I'll just go through. And like we all know, there can be refractive surprises even with toric IOLs also, maybe because of misalignment and other things. Errors usually it can arise. There are various ways you can do it, but the common errors are that either pre-op measurement errors, or if the marking of the reference marking or axis marking is incorrect, or the incorrect placement of the lens, and failure to take into account the impact of surgically induced astigmatism. There are other reasons also which are not that common. So now let us go through certain examples to highlight these things. So case a patient who 60-year-old female with a grade 2 sclerosis was not a difficult case, but her corneal astigmatism was more, 2 diopters at 150 degrees. So lens was chosen for T5, toric lens was implanted, and surgery was uneventful, but post-operatively patient accepted -4 diopter cylinder at the same axis. That means we have added another 2 diopters to the existing thing. Because of the wrong entry. So this is quite common actually, isn't it? So best thing would be to before surgery just look into the chart. See, many of us may not have time to do everything by ourselves. Your optometrist can do mistakes. So best thing would be to go through the charts. So that is a cause, and then another case where it was a simple cataract and surgery was uneventful, and the toric lens was implanted, but post-operatively patient accepted again cylinder. With correction, it was coming to again. This was because of wrong alignment of the axis. So it could be because of incorrect reference marking or in the post-op IOL rotation. So we speak so much about rotational stability, which may not be there with most of the other lenses. So we all know that 1 degree of rotation then results in 3.3% of the cylindrical power loss, and 30-degree rotation it becomes like a spherical lens. So axis rotation, how it can be done in various ways. How much to rotate after implantation of the lens? How much to rotate? So there are various ways again. iTrace comes to help. This is what I use regularly. So here, as you see, the reference markings are not equal. They are not at 0 and 180 degrees. One is at different point, other is at 170 degrees. So Zaldivar caliper helps us. There's an option where how much you should rotate so that you get the desirable axis. Otherwise, so here, for example, this case, this particular case, patient required a 2.8 diopters of cylinder astigmatism, and then after rotation of about 30 degrees, it came down to almost 0.4. Then we have online calculators like astigmatismfix.com. There are so many other online calculators which tell us how much we should rotate. And the another question is how early you should rotate the thing. How, see, before the fibrosis sets in. Usually it's said 2 weeks, 1 to 2 weeks, but some people say 4 weeks. So again, suppose patient comes to you at the after 6 months, still we can go ahead and do it. Only thing is you will have to uh, separate the lens from the fibrous capsule and then rotate it, and so take all the precautions like that. Another patient, a female, like just now we discussed about pterygium surgery. She had nasal pterygium, which was recurrent, and so first pterygium surgery was done, and then later on patient insisted that she wanted multifocal lens, so toric multifocal lens was implanted in that case, and to my surprise, the astigmatism went on increasing, and it stabilized at the say 16 weeks even after surgery. Yeah, so it was around 4.5 diopters, and then every time she used to come and then occupy the chair for a longer period. And so the main problem here is like what we discussed. Once you do pterygium surgery, all the cases need not follow the same pattern. So one will have to wait for at least the cornea to remain stable. So one simple way is your chatometry value. Not everybody will have access to topography. Otherwise, best thing would be to have a topographic stabilization. So once you do that, then you assess the thing and then go ahead with the surgery. So not before that. Another case where a toric lens was implanted of about 3.75 diameter, and a diopter cylinder. It was implanted at 32 degrees because the chart also showed the same thing, but patient required the same minus 3.5 diopter cylinder with additional sphere, and then the vision was not good, so patient was not happy with the thing, and again went back and checked the axis was corneal astigmatism was correct, the corneal measurements were correct, the topography was normal, and then so what went wrong was so after rotating the lens by about 120 degrees, patient started accepting because the pre-op astigmatism was 3 point pre-rotation astigmatism was 3.5 diopters at 30 degrees. So rotating to 120 degrees, patient was happy with the 0.5 cylinder, and I was able to read up to 612 because of amblyopia. So here the main problem was probably, since all other factors were all right, so it was probably a faulty lens. And in fact, if you go through the net, there are a lot of articles on this. Your lens can also be at fault. So we need not blame us only, ourselves only. Another case where a patient underwent surgery in both ways because he had diminution of vision, and then he didn't give he was wearing contact lenses for a longer period of more than 30 years. He was a diabetic, retina was normal, and it was a simple case, so surgery went on very well. Pre-op refraction was somewhat like this. Since left eye didn't have much of astigmatism, only paired opposite clear corneal incisions were made, and then right eye toric lens was implanted after taking into account all these things. But post-operatively, patient had this much of astigmatism which he didn't accept. He wanted something better. That is again due to maybe because of aggressive counseling that we do. So probably what was ignored was, after surgery topography was done, and this was the thing. It was a case of an aborted keratoconus. Patient didn't realize. Throughout he was wearing contact lenses, and he had reasonably good vision. So bilaterally it was like that. And then if you just look at the higher aberrations that were present, it was much more. Say around coma was around 1.6 in one eye, and the other eye was also more. So higher aberrations were more, and this was explained to the patient that your cornea is not healthy and it's better not to touch it now because it can lead to other problems also. So finally, the patient has settled down with the existing correction. So the take-home message here is, first we should take along with, I mean, normally we take, but any patient wearing, say, rigid contact lenses for a longer period and getting good correction only with the contact lenses, then that should we should start thinking in this in these terms. And such selected cases, it is better always to do corneal topography pre-op, so that counseling would be better. Otherwise, you'll land in trouble and your chair time will increase. Otherwise. Another case where LASIK was done about 20 years back, and now probably future this is going to be the thing. We also always ask the patient. So patient had, it was a simple cataract, and after thorough counseling, he underwent phacoemulsification with the toric multifocal lenses or the trifocal lens now. And then post-op result was like this, somewhat like this, but patient was not happy because he had paid so much of money. And then the topography showed higher the corneal wavefront aberration showed higher order aberrations of almost 1.5 of coma and so like this. So and spherical aberration was more. So patient was not happy. Initially thought of doing IOL exchange for this patient, but after looking at the higher order aberrations, we thought it's better to treat the cornea rather than doing the IOL exchange. After doing topo-guided PRK, patient is now 6996 both eyes and happy, reasonably happy. So it is always better to rule out the higher order aberrations. Always look at the cornea because that is what you are going to correct. And corneal astigmatism, which is not just the axis which is going to tell. So patient having higher order aberrations, and then treat the cornea prior to surgery, or probably this will help us to do proper thorough counseling. They should not expect very good results with a bad cornea like that. So it need not be a picture perfect result all the time. Toric IOLs can be, I mean, the results can be elusive. Similar to post-op spherical error surprise, toric IOLs can also throw a surprise for various reasons, which we need to address. Thank you very much for your patient listening.
Thank you, sir, for sharing a complex series of cases. I think once we begin with simpler cases, we end up having all these situations. And thank you for sharing your experience. What would be the right time and the technique to rotate the lens when you have noticed that there is the axis is wrong?
Right.
You flip the axis, you put in wrong
No,
axis.
that's what. So I prefer to do it as early as possible before the fibrosis
See,
sets
I think
in,
that's an
maybe about
important message.
1 to 2 weeks.
So
But
yeah, you want to see the refraction stabilizer, say 1 week or 2. If it doesn't, then I think you should not wait further.
correct. That's
Go
right.
in and
Wait
then
for the
do it.
yes.
It is not very difficult to rotate the lens at all. Just don't wait on it. Sit on the patient. An unhappy patient is going to go to the next doctor and he will point out the mistake. So just maybe 2 weeks would be ideal, not more than that. That should be easier to rotate even these hydrophobic lenses.
Also, sometimes we think it's a very small amount of rotation, it won't matter, but actually even small rotation matters a lot in toric lens, especially if you're dealing with a higher cylinder. If you rotate 30 degrees, the entire effect of the toricity is gone.
It's gone.
So the one interesting observation that I've had with this Zaldivar's caliper, since you mentioned that on the eye trace, is that even if you have a happy patient and zero refractive outcome post-operatively, you ask them to sit before the eye trace and take the Zaldivers, it still shows you a rotation. So that's
Correct.
one thing. So it perhaps is inclined towards indicating a post-operative IOL rotation, which sometimes might not be necessary. I mean, it's just an observation. Obviously, why would you ask the patient to sit before the eye trace if the patient is happy? The other thing is the refractive outcome, if is like a neutralizing each other perspective, like a +2 with a -2, a +2 with a -4, they actually respond the best to IOL rotation. So even if the patient does not accept it, if the autoref shows a +2 with a -4 cylinder, meaning neutralizing each other, the spherical equivalence becoming 0, they are the best candidates for an IOL rotation. They behave the best post-rotation too.
Yeah, I think whether I don't know whether it was mentioned. So there is a site www.astigmatism.
It was mentioned.
Yeah. So I think that's the thing, that whatever you have, put that data, and it will tell you whether rotation will solve the problem or we have to explant and change. Yeah.
Any one question from the audience? Anybody wants to have a question from the audience? One question. 2 more minutes we have. There's a hand somewhere? Yes. Okay, hand. Okay, sir. Boramani sir.
I just want to ask one simple question to all panelists. Forget about the surprise shown by Dr. Satyamurthy. How many of you are routinely get or percentage wise the moderate surprises, say only 0.5 diopters of astigmatism, is irrespective of or in spite of proper calculation, no errors, nothing, perfect surgery, no heating of the cornea also. But on an average, say, or no one is getting say 0.20, say 0.5 astigmatism.
You mean to say after toric lenses?
After toric lenses.
I think
very common.
Very
Very common.
Is it
We target only that 0.5 only, sir. We don't target 0.
Zero.
Many phaco surgeons, they're advocating toric for 0.5 also.
Yes.
That's why I'm asking.
0.5, if it is against the rule, then it amounts to almost 1 diopter of astigmatism. So for against the rule 0.5, we have to correct it.
No, for with the rule 0.5, it will not even show you a toric requirement, the calculator. The question here is, sir, even if the output is 0.5 and you're trying to correct a 0.5, a lot of times we face this question, does it need to be corrected at all? So the point here is, when you are giving glasses to the patient post-operatively, you are essentially correcting the lower order aberration some distant away from the nodal point. With the toric IOL, you're correcting that lower order aberration very close to the optical center. It still gives a wow to the patient, even if it's 0.5. So the counseling has to be, if the patient is already wearing glasses and is happy with it, then I quote them my example. I have been using glasses for 42 years. I'll be very happy to shed with it, to do away with it. And if the patient is not wearing glasses and has a cylinder, it's even easier to counsel. You're not wearing glasses, you would perhaps not like to wear glasses even after you're operated. So 2 ways of counseling, but they meet at the same point.
Sir, quickly, last point.
Yeah, I just wanted to emphasize that when you're doing a trifocal IOLs, and then the toricity becomes a very sensitive issue.
Yes, absolutely.
And therefore, even if you have 0.5 diopter of astigmatism required, it has to be corrected.
Absolutely.
Because there are situations, if you feel that it was 0.5 and you have not done it in one eye, and then they don't have that good vision, if you correct it in the other eye, they would keep on telling you that this eye is not good.
Absolutely.
So in trifocals, toricity has to be removed.
Absolutely.
I think for toric, lack of money is the only true
can I add one thing?
contraindication.
I think we are running out of time, sir. I think
just 1 minute. I'm
yeah,
only.
sure,
I'll
sure,
not
sure.
take more time.
Sure.
See this. If you really are looking at, I mean, point blank thing. I mean, it should be completely zero. Then probably you can go ahead with the PRK and do it. Probably with the laser vision correction can achieve good results in these cases.
Okay.
What about pediatric cases? Say the age group is between 13 to 15 and cylinder is more than 2.5.
Yeah,
Will you plan for toricals?
Yeah, of
for
course. I think, of course, we have.
Most children have with the rule astigmatism, and it's going to go on reducing. Or so generally under correction. That's what I do.
Usually mild undercorrection, because once they cross 40,
mild undercorrection,
it's going to have with against the rule astigmatism progression. So mild undercorrection. But anything which is more, no, you have to undercorrect.
Save for the patients wherein it's difficult to take a proper biometry. If the patient has an nystagmus, for example, if it's not taking a proper biometry, then the equation changes.
Yes, a corneal incidence is an option, but the problem is they are not as predictable as the toric IOLs. So that is
the OCCIs? Oh, no.
So thank you all of you for being here, and I thank my the co-instructors for this case. I hope it was fun. And if you have any doubts, any questions, please, when you're off the dais, you can have a discussion with us. Thank you so much.